All right, so thank you very much for inviting me, everyone. I'm Kylie McArdle. I'm one of the intensive care specialists at Gosford and Wyong, and I do know some of you from our earlier days as interns and residents. I'm really excited to be here, and I'm really hoping that this can be a collaboration with the Primary Health Network and all of the GPs on the Central Coast. So I think the title previously was something different in the agenda, but what I'm sort of really, I suppose, here to talk about is post-intensive care syndrome, what that is, why we're interested in it, and I think how we can work together to help people who have particularly complicated and long ICU stays after they leave the ICU and certainly once they get back into the community. So I wouldn't say this is a typical of every ICU patient, but this is certainly, a patient who has a sort of more complex ICU stay with multi-organ failure. This is what we do to people in ICU these days, and as you can see, I think this can be incredibly traumatic for our patients. There's obviously good intentions here. We are trying to help support them through whatever illness they've come in with so they survive, but surviving well is something that is becoming much more important as our technology gets better and more people do survive their ICU stays. So for people who may not have been in ICU for a long period of time or sort of spent any time in ICU, there's a dialysis machine here and these big catheters that are coming out at the base of the bed there are going to an ECMO machine. So this is one of the COVID patients in one of the Melbourne ICUs, and this is sort of all the stuff that's required really these days to help a complex multi-organ failure patient survive. What's happening after ICU stays like that is becoming more and more I suppose public. So this is an article from ABC only a few weeks ago looking at delirium and PTSD and what's happening in this sort of post-intensive care syndrome space. The young girl here is actually a lung transplant recipient, and it's very stark what she talks about in this article and also on the podcast in terms of her experiences in ICU and really just how terrifying ICU can be for patients, particularly those who are ventilated and are under the influence of a whole heap of different sedative drugs, and as they become, or as they're weaning from ventilation, there's a really high rate of delirium, and so delirium really can be really terrifying for patients, and that's one of the main things we're concerned about, those long-term effects as well as the effects of all of the other stuff that happens to people and how they recover from that. So post-intensive care syndrome is defined as new or worsening impairment in physical, cognitive or mental health status. It can be one, it could be all three, arising after critical illness and persisting beyond discharge. And there's also a subset, in the evidence now it's referred to as PICS-F or PICS family, because there's also significant effects, acute and chronic, for the families and loved ones of the patient in the ICU. I think it becomes, ICU when you work there all the time, becomes a normal environment, and you lose sight sometimes of the fact that this is the worst thing that's ever happened to these people, the patients and their families, and it has some significant short and long-term effects. So this is a sort of spectrum of all of the different things that are seen in PICS. Clearly, not everyone has all of them, but there's a high prevalence of all patients having at least one of them. Physically, having ICU-acquired weakness is something we see when we have long-term ventilation, use of steroids and paralysis agents, particularly in respiratory failure patients. People who have organ failure, particularly acute on chronic, and that having pre-existing and nutritional deficiencies during their stay. Cognitive, prolonged delirium. Lots of people have cognitive impairment after prolonged ICU stays, and new cognitive deficits. It's much worse for people who have pre-existing cognitive deficits, which is a real issue because a lot of our patients are in the older age group, and they already do have this. Sometimes it's not well recognised or diagnosed. And certainly, as just described, the psychological impacts. PICS sometimes is sort of seem to be synonymous with PTSD. It's much more than that, but there's certainly a PTSD component to post-intensive care syndrome. Lots of patients describing nightmares, hallucinations, vivid dreams, and having those kind of, in that delirium, things that we think are, I suppose, not very significant or relevant, being quite terrifying for them. So laughter in the unit, footsteps, feeling like people are holding you down underwater. There's all sorts of terrible things that people describe when you actually ask them. They don't often offer it. If you don't ask, but when you start to actually ask them about what their experience was like, particularly when they were ventilated and sedated, there's some pretty awful things that they, vividly remember. The risk factors are, prolonged stay in general. So, prolonged being more than 3 days is the sort of definition. But certainly having, more than 3 days on a ventilator, having acute respiratory distress syndrome or delirium for any reason, multi-organ failure, and, all of the things that go along with that. Pre-existingly, clearly older age, it has a bigger impact, female sex and pre-existing disability and cognitive impairment, as well as mental health diagnoses. I think the reason that, it's probably always existed in terms of, ICU patients who have prolonged stays. It's got, I think, increasing prevalence, but also we actually have an increasing number of survivors from severe critical illness and an increasing number of older survivors. So, it's really not uncommon for us to have at least one or two 80-year-olds or close to 80-year-olds in the unit. I've got 2 at the moment, and, that really, I think, does have an impact on them, particularly in their recovery. So, as I said, up to 75% of survivors will experience some form of significant impairment, and impairs their recovery to the previous level of functioning. I think it's in its infancy in terms of how we go about managing this. There's a few things we can do to try and prevent it, but really it's about coordinated and targeted intervention once you've identified that they're either at high risk or that they actually have PICS. In ICU, we've moved to do it towards a few things to try and prevent at least the severity of PICS. So we try and reduce the amount of sedation we use as much as possible. We have, ongoing delirium assessments. We try and get patients moving as early as possible. Some intensivists are actually mad keen on moving and mobilising people who are still ventilated, particularly if they're not ventilated for respiratory reasons. I'm not one of them. I'm a bit of a wuss, but certainly there's lots of things that people are trying to do to try and help prevent this. In our ICU, we have actually just started the use of patient diaries. So for anyone who's expected to be in ICU for more than 2 days, particularly ventilated, we're starting an ICU diary, and that is, we've got a set of them at the in the unit. We have it at the bedside, and we encourage families and all health staff to write in the diary about what's happening for the patient every day, in language that patients and families can understand. And in all of the evidence that we have so far, the only thing that seems to make a difference in terms of severity of PICS after these kinds of ICU stays is the ICU diary, and that ability for that period of time where the patient either has a big blank space of memory, or they have memories and of hallucinations and sort of terrible things happening. The ability to go back and actually read what actually happened to them on each day seems to be quite important in terms of psychological recovery, particularly. We're really behind in general in Australia in relation to PICS, and the whole world was really up until last year. The UK really got their act together very quickly and have set up a framework for early rehabilitation intensive care. It's basically a framework for PICS. It's not just about COVID. it is being utilised for all patients, and I'll just quickly go through that in a sec. So this is kind of, I know it's a busy diagram, so apologies, but you know, what basically it is you come into ICU, you assess, you've got a risk assessment, you set some goals, you try and prevent PICS, you know, you have a assessment towards the end of your ICU stay, a rehab prescription, and then you're sort of forwarded on through various referral pathways to try and manage whatever's been found in the assessment, in the multidisciplinary assessment process. So we're really keen to actually start a program, a coordinated program out of the ICU, you know, looking at how we prevent, risk assess, identify, and then refer and manage, and then and how we coordinate that with everyone in both the hospital and the primary health network. So there's sort of 4 pillars of the program that we're proposing: education, prevention, rehabilitation, and governance. And I see, obviously, all of you as a kind of, I suppose, the integral part of the rehabilitation process in the community. And I think that it would be really valuable, and why I'm here is to get your input on what you think, you know, we could do, or what's needed in terms of coordinated care pathways, increased resources. And I know that there's lots of allied health and community centre and care resources that are difficult to access, and there's not enough of them. But certainly hoping that we can work together to figure out where the gaps are, how we can link it all together to better help these patients. We're also really keen on doing an ICU follow-up clinic. There's 2 of these already in New South Wales, one at Nepean, I think one at Prince of Wales. That's an opportunity for the patients to come back to ICU if they want, to talk about their experiences, to potentially see the unit, and ideally a place where we could assess and refer. I'm not quite sure we've got the resources or the setup for that yet, but longer term, that's where people are heading in terms of ICU follow-up clinics, and certainly in the UK they've already got those. So really now we're at the stage where we're consulting. We have executive sponsorship thanks to Fiona, and I'm basically moving around trying to speak to as many people as I can who, you know, would be involved in a process like this, both in the hospital and out of the hospital, to see what their ideas are to feed into a process of developing the program and all the pathways that are going to be required. And after that, there'll be some development of resources for both patients and families and clinicians. So we're going to base this on the kind of model from that Intensive Care Society in the UK. So we'll have a screening tool which will be based on their screening tool. Then that will determine what referral there is to professional assessments, inpatient and or outpatient. There'll be a prescription, information and education for patients and families, and then referral on as people move through the system and go home. These are just sort of rough kind of, I suppose, you know, documents that we've come up with so far. We're in the early stages, but this whole process we really see as involving the primary healthcare providers and the GPs early, and through the use of actually having an ICU discharge summary, which gives more targeted and specific information for the GPs about the ICU stay early on. You know, we would be looking to try and get this to you guys around the time that the patient's actually discharged to the ward. So you know what's happened to them in ICU, you know, potentially what might be coming and what their risk, you know, is for this. So we can start thinking about how we coordinate their care when they move back into the community. And clearly some of these patients are on the ward for weeks to months. But, you know, trying to start that early is a good idea. And I'm also cognizant that a lot of the family, as patients are in ICU, probably go to their GPs for support in relation to the stresses that are occurring as a result of those ICU admissions for their family members. So this might help GPs to understand what's happening to them, you know, in the hospital. These are some of the patient resources that already exist that we're going to kind of sort of steal from, I suppose, or borrow from in a way to make up our own. And having, patient resources and family resources, so for PICS family as well. So in terms of what it means for GPs, I'm hoping that it means that there's improved communication and collaboration and quality of information. Again, the discharge summaries that I'm sure you get at the time of discharge from hospital usually just have, admitted to ICU for this many days, and then it's kind of just this big blank space. Part of that, I think, the problem with that part of the problem is that our two systems in the hospital aren't linked. The electronic medical record system for ICU is actually separate to the EMR system that generates the discharge summaries that go straight through to you, and it doesn't necessarily auto-populate anything. It doesn't auto-populate anything from the ICU discharge summary from ERIC, as we call it. So there tends to be a bit of a hole there. And hopefully during this process, having some better tools, some tools for primary care and some pathways and coordinate care processes. So really why I'm here is to get your ideas and your feedback. Do you think this is a good thing? Is it worthwhile? What would you like from us in terms of, particularly ICU, but how do you see this working in the community? And what do you think in terms of processes for coordination of care? Should that be you guys? Should there be more of a complex care coordinator situation, which I know we have for some other conditions in the community? Really just hoping to get your ideas and have a chat about what you think. I'm going to stop presenting now.
That's fantastic, Kylie. Thank you so much. It's a revelation to hear you speak like that. I think I'll pass it over to the other GPs to comment first. Does someone want to start? Volunteer to start?
I'm happy to start. It's Taya. Hi, Kylie.
Hello.
That was great. I think you've outlined it really clearly and where we fit into the picture. And I think the discharge summary from you guys would be a perfect way to start. And it looks quite simple, and it's probably what it needs to be, I think, knowing that our patient has had a long stay or a stay in ICU. And that we're then prepared for when they come out. I guess just in discussions, it would be then maybe some guidance about how we can help our patients through, and that might be just further reading for us. I can see another health pathways being formed here for PICS, and what resources are available for our patients. I think as GPs, we would be quite capable of coordinating that care if we know where the resources are and if they are available. So, so that would be, my comment. But I think it's great. I think you've done a great job. And it's really nice to hear why things don't happen, like the fact that Eric doesn't speak to the other electronic system. So we have no idea about that. So that's really good to understand the problems or the hiccups along the way in communication. So I think all that helps. The more knowledge we all have, it helps.
I think I'm really hoping, excuse me, I'm really, like, the ICU discharge summary is something we could try and get off the ground pretty quickly. Like, it doesn't have to happen as part of this big, broader program. If we can put something in place, relatively quickly, that could just happen. Anyway, I think at this stage, given the resourcing, it'd probably only be for people who have, more than a 48 to 72 hours stay. We have lots of people who just kind of transit for 24 hours in, short stays, but I'm hoping that we could sort something out that we could start doing that a bit quicker, and eventually link it into the EMR system so it can just automatically go to you as soon as it's completed.
Yeah, well, maybe, by all means, start it, and then if we receive them, we can give you feedback, I guess.
Yeah.
How many we're receiving, if it's timely, if it's helpful. I don't know how can you do that electronically?
So not through ERIC, and that's the big problem. So, but I'm thinking that we could potentially actually just put a template into EMR and do it that way. Just like we do, because we can, in EMR, there's clearly a standardized electronic discharge summary that is there, a general electronic discharge summary that is there, but you can make your own templates. I think that the whole getting it faxed to you automatically is something that would have to go through the IT committee and having, you know, approvals and all that sort of stuff, which is, they've got a real backlog at the moment, but I'm sure there's a way we could work it out. And there is like a capacity in the current template for if GPs sort of get it and go, oh, I don't know what this is, I've never had this before, to just call us and talk to us. There's a ICU liaison service that we run. It's run by senior nursing staff with medical oversight, and they are there every day from sort of 2 to 12, and they would be sort of the first point of contact, or one of the consultants.
Yeah, well, just that presentation you gave, if that was put out to GPs generally, you know, the people that watch that would then understand what they're receiving, and that would catch quite a few GPs. Yep.
Yeah, no, I'm happy for it to go up wherever it needs to go.
That's great. Thank you so much, Taya. Con, did you want to build on that? You're next on my screen, and we'll call you out.
Oh no, thanks, Ellie. Thanks, Kylie. That's fantastic. Yeah. Just add on that, probably. Not to increase too much work, probably just a small phone call, because on a lot of times, you know, we get phone calls from particularly relatives saying they don't know what's happening in ICU. You know, they've been there for 2 or 3 days, and I'm sort of like lost. I have no idea. I'll call, but I have to admit, the times I call, you know, the registrars or the RMOs, they've been fantastic in terms of sort of giving a bit of a summary that I can relate to the families. So if there's a possibility of a phone call to the GP.
Yeah, I mean, certainly that could be something we try and work into normal business. I think it's actually more important now because there is, I mean, we've just had visitors start coming back today, but it's been very, very challenging communicating with families as well as trying to look after all of the patients in new COVID world, and particularly the COVID patients, who I'd have to say, you know, of the 5 we have in at the moment, I think 4 come from primarily non-English speaking backgrounds. So trying to communicate with their families has been really hard. And I suspect that a lot of them are coming to their GPs to try and find support and answers and explanations. Yeah.
Thanks, Con. Yeah, we're always super happy to get phone calls from you guys, so more the merrier, I think. Georgia, you're next on my screen. Did you have any comments or thoughts for Kylie?
No, I echo what Taya and Con have mentioned as well. And yeah, again, to be informed like halfway through their admission, so when they are going from ICU to the wards, often we've got no idea what's happened until we get the discharge summary, if we get the discharge summary. So to know halfway through, again, we treat a lot of the patients' families so we can support them. And also we know that when they're discharged, we'll make sure we've got a triple appointment ready to see them, because often there's a lot to go through. So it helps us be more prepared too. So I think
absolutely.
That's great. And Nat, did you want to build on George's comments there?
Yeah, I dropped out for a second. I managed to find the link back in. Thanks so much for that, Kylie. That was great. Having spent no time at all in ICUs since 25 years ago, personally or professionally, gratefully. There were things there that I hadn't even thought of. And I think the thing is, by the time we often see our patients, they've actually had a transition back to the normal ward and then through rehab often, and it's many, many weeks later that we actually might see them in our office. So knowing what happened in ICU would actually be really, really helpful.
Yep, great. Thanks, Nat.
And Karen, just I'm mindful that Gillian Isaacs has just jumped on and it's 7:30, so we'll keep it brief for Kylie, but I'm sure you've got more thoughts, Karen. Thanks.
Thanks again, Kylie. It was great. Just a couple of comments, and I reiterate what all the GPs have said. I think one of the reasons the discharge summaries have often got a big space in them is that the junior GAMOs aren't always aware of what's on either. So what you're sharing with us, I'd really encourage you to share with the team that's taking them out of ICU, and that what you've written in that discharge summary gets probably cut and pasted into the final discharge summary, so that there's a bit of a link into that. With your permission, I'd love to get this video and put it up on GP Association and the community of practice sites, because we can share that quite quickly and easily amongst quite a lot of GPs. And the screening tool you were talking about as patients were leaving ICU, my suggestion is that screening tool be used over a number of weeks or perhaps even months into the future, not just at the time they're leaving, because most of these PTSD kind of issues come up afterwards down the track, and we need to reassess, what's happening there. So maybe looking at that screening tool being used at, day 0 and day, 1 week and 1 month and 6 months or something might help.
That we absolutely want to do that. We've actually got, and there's another one called Promise 29. I don't know if you guys have heard of Promise 29, which actually seems to fit quite well with PICS. So we would certainly love to be able to do that. I think for us, we'd have to have some resourcing to be able to, we want to follow up at 1, 6 and 12. We want it to be part of clinical care though, so we have to have appropriate, if we identify that there's an issue, we have to have appropriate referral pathways and support around that to make sure that we can help the people that we're screening. And so that's where we're kind of a little bit at the moment, what that's going to look like, should we really be the ones that are doing that? But certainly I completely agree that there needs to be ongoing risk assessment and screening, not just at the ICU discharge. Yeah.
Kylie, it's Fiona. We can probably set that up through REDCap and our patient experience role.
Yeah, I was thinking about that. Yeah. But again, Fiona, I think, if they're going to do that, then that in some ways I wouldn't want them to do it on their own, and then as they're doing it, figure out that there might be some, that oh yeah, hang on, I am having some issues there. What do I do with this information? Where do I go? Yeah. I think that probably needs a little bit more thought.
Yeah. I'm familiar with the Promise 29. It's a really good one. We've been doing it at the Aboriginal Health Centre for some of our patients, but it would take just a simple GP education session, maybe not even, but we can take that on, certainly for the post-discharge risk assessments, and we can continue that and help coordinate care as required, as long as we knew what to do if you give us specific instructions about what's needed and when. I agree with Taya that we'd be very happy to continue that and help arrange appropriate allied health and psychologist referrals and everything else.
Yep, I think that would be great.
Oh, that's so good.
Can I just add that, I echo Taya's feedback that I think it would be really perfect for health pathways. Happy to work with you, Kylie, and the GPs on if you want to host information on health pathways.
I'm really sorry, I don't know what health pathways is, but I'm more than happy. If you guys think that it's something that would be helpful, I'm all there.
It's a website for GPs, so we can host a whole lot of information about all of the referral pathways and so on.
Yep, that sounds perfect. Thanks, Eric.
Yeah, and Catherine Turner's just commented in the chat that it'd be helpful to send this talk from yours, Kylie, to appropriate allied health providers so that they know what's going to be involved in post-ICU discharge care. So I think that's a good idea too. Yeah.
Sounds good. I'm certainly going to try and I'm meeting with the inpatient, or actually the sort of inpatient / community allied health manager. So, but yeah, certainly private providers. I'm happy for it to go to them as well.
That's great. Are you happy with what you've got from us tonight, Kylie? Does that give you something to start with?
Yeah, that's excellent. Thank you so much.
Did you feel like you wanted to come back and have another chat sometime, maybe early next year, or are you happy to just link in by email, let us know how it's going? And
I'm happy to do both. I think it'll probably take, given we're sort of still, I think that this is going to be a funny transition period with COVID, particularly from ICU's perspective. We're not quite sure what's going to happen. So I think it's probably going to take me another 6 months to really get things off the ground. I would be keen to do the ICU discharge summary before that, and I think we can manage that. So, but yeah, I'm happy to do both.
Great. Oh, thanks so much for coming along. It's
no worries. Thanks for having me. All right, thanks, everyone.
We'll see you later.
See ya.